Imagine this specific moment. It's 3 a.m. in the emergency department. The digital tracking board is glowing red, signaling the unit is completely at capacity. You desperately need to move people through, but there is no discharge planner on call. It feels like a standard logistical failure, but then you look closer at why the beds are full. You see a patient in bed 4. They didn't have a sudden accident. They are there because they quietly started rationing their insulin again. You see a family huddled in the waiting room, terrified because they delayed a crucial infusion treatment due to cost until the symptoms became impossible to ignore. What is striking is the disconnect. Outside these walls, policymakers are using clean professional terms like fiscal responsibility and unwinding subsidies. They talk about numbers on a spreadsheet with a sense of calm authority. But standing there on the floor, you realize those polished phrases are just a mask. Inside the hospital, that responsibility looks entirely different. It looks like untreated infections, closed maternity wards, and higher mortality rates. It looks like a system that isn't just cracking, but actively turning on the caregivers trying to hold it together. The ground is shifting, and what is being sold to the public as saving money is actually a quiet collapse that relies on the silence of the people standing at the bedside. That opening, it's not just a dramatic scene, is it? It's the daily reality for so many healthcare workers right now.
It is. And that's why we're here today. We're going to do a critical deep dive into that very disconnect.
Right. We want to move from that visceral, really traumatic reality you see on the hospital floor to the intellectual mission of connecting it all back to the highest levels of macroeconomic policy.
Exactly. We're talking federal budget cuts, subsidy expirations, things that sound so abstract.
But they're not abstract at all. We're basically going to trace the dollars, or the lack of them, from Washington, D.C. straight to that patient in bed 4.
And it's so essential that we do that. We have to move beyond just acknowledging that there's, financial distress.
Yeah.
We need to analyze the specific policy mechanisms that are actually generating this systemic failure.
Okay, so how are we going to structure this deep dive?
I think we can break it down into 4 critical areas.
All right, what's first?
First, we have to understand the projected economic shock. We really need to get our heads around the number.
So things like the expiring health coverage subsidies, the big federal budget cuts.
Precisely. The question is, just how large is the hole that these policies are about to tear in the healthcare system's finances?
And after we have established that economic shockwave,
then we'll track how that shock translates into an operational collapse.
Okay, so that's the instability for providers, the hospital closures we keep hearing about.
Yes, especially in rural areas. And crucially, the steep, really unmanageable rise in what's called uncompensated care that providers are just forced to absorb.
And we have some real-world stories to illustrate that.
We do, because the numbers only tell half the story.
Then, after the financial and operational view, we have to get to the human consequence.
This is key. We're going to differentiate between what people commonly call burnout and something much, much more damaging.
You mean the escalation of moral injury?
Moral injury and workforce trauma among clinicians who feel profoundly betrayed by a system that's stopping them from providing good care.
And finally,
we have to put the entire U.S. system into context.
The global comparison.
Right. We'll compare its astronomical costs and, frankly, its poor outcomes against other high-income nations that prioritize universal access.
And that comparison should help us understand not just what is failing, but why our foundational choices seem almost designed to maximize cost and minimize equity.
That's the goal. Let's unpack it.
All right, let's start with that first major policy wave that's about to break over the system. The expiration of the enhanced premium tax credits, or PTCs. We probably need a little bit of history here, because this wasn't just some minor budget tweak, was it?
No, not at all. You're absolutely right. The enhanced PTCs were first adopted back in 2021, part of the American Rescue Plan Act, and then they were extended again in 2022.
And they were, for lack of a better word, revolutionary for the individual insurance market.
They really were. Their main function was just to substantially lower the net premiums that people were paying through the Affordable Care Act marketplaces.
So what made them so effective? What was the big difference between this enhanced version and what we might call the standard version?
Well, under the enhanced PTCs, the percentage of your income that you had to pay toward your premium was drastically capped.
Okay.
And crucially, they extended eligibility for these subsidies further up the income ladder. But for people at the lowest end of the spectrum, say, earning between 100 and 150% of the federal poverty level,
the
enhancements reduced the cost of benchmark silver plans to 0.
To zero. So they made coverage genuinely affordable for the first time for a lot of people.
Exactly. And the success is measurable. I mean, you can see it right in the data. Marketplace enrollment more than doubled since the enhancements took effect.
Which just proves the point, right? When coverage is actually affordable, people sign up for it.
It brought millions of Americans into a stable system, many of whom were previously uninsured or just churning through these terrible high-deductible plans.
It stabilized the entire market, really.
It did. But that's the core concern now, this massive affordability cliff that's waiting for us if the policy reverts back to the standard PTCs after 2025.
And this where the numbers start to get, well, they get pretty frightening.
They really do. The projection is that 4.8 million more non-elderly adults will become uninsured in 2026.
4.8 million.
Just like that. It's a massive hit. It increases the national uninsured population from about 23.2 million to almost 28 million people.
Wow. And you mentioned before we started that this number is actually higher than some of the prior estimates. Why is that?
It's a bit of a paradox, really. It's because the enhanced credits were so effective at increasing the baseline enrollment.
So the pool of people who are now dependent on that affordability is just bigger?
It's just larger. The more people you cover successfully, the greater the catastrophe when you pull the rug out from under them.
Okay, let's talk about that affordability cliff in real terms, because this is where the policy mechanism gets really clear. When we snap back to the standard PTCs, how does that cost burden shift so dramatically onto the consumer?
Well, under the enhanced rules, no one was required to pay more than 8.5% of their household income toward their premiums.
Which was a huge deal for a lot of families.
It was. But when the rules snap back, not only does that percentage increase significantly, but the subsidies they disappear entirely for anyone earning over 400% of the federal poverty level.
Okay, this is where it gets really interesting and really dangerous for working families. Let's take a hypothetical. A middle-class family of 4, maybe they earn about $120,000 a year.
Right, which is roughly 400% of the FPL.
So under the enhanced PTCs, their premium contribution might have been capped at that 8.5%. Maybe, $850 a month? Still a lot, but manageable.
Manageable, exactly. Now, what happens when the standard PTCs kick in?
Their share goes up.
It could now be 10 or even 12% of their income.
Yeah.
That could push their monthly premium well over $1,200.
And we're going to talk about a real story like that in a little bit.
We are. But think about the family just above that 400% FPL mark. Let's say they're earning $130,000.
Under the standard rules, their subsidies
Vanish completely. They go from paying maybe $900 a month to suddenly facing the full sticker price of a family plan.
which could be, $2,500 a month?
More easily.
Nah.
That kind of jump is catastrophic. It forces them to either drop coverage entirely or, maybe worse, opt for these disastrously high deductible plans that leave them effectively underinsured.
So we're looking at a huge contraction in the marketplace itself because coverage will just become unaffordable for the working middle class.
Exactly. Marketplace enrollment for people getting these tax credits is projected to drop by 7.3 million people.
7.3 million.
It's a 38% contraction. It falls from 19 million people down to 11.7 million in 2026.
Yeah.
This is market instability on a grand scale.
Where do all those people go? We know not all 7.3 million of them become uninsured.
Right. A portion of them, we estimate about 3.2 million, are expected to switch back to employer-sponsored insurance, or ESI.
And that's a crucial counter trend, isn't it? Because ESI is a very different animal for the healthcare delivery system.
It's a vastly different animal. From a provider's standpoint, ESI often represents higher quality, more stable coverage.
Why is that?
The plans typically offer higher reimbursement rates compared to marketplace plans, and the network negotiations are usually more reliable, more stable.
So for a hospital, a patient with employer coverage is financially a safer bet.
Generally, yes. But here's the thing. Even with millions switching back to ESI, you still have that sheer loss of 4.8 million people dropping into the uninsured ranks.
And that still creates a massive hole in the guaranteed sustainable revenue streams for the providers who are serving the rest of the community.
It creates a huge gap.
So that large-scale coverage loss, it translates immediately into an economic contraction for the providers themselves. They're just losing guaranteed income.
Instantly. Let's try to quantify that lost revenue.
Okay.
The total national healthcare spending for the non-elderly population is projected to decrease by $32.1 billion in 2026.
$32 billion.
It's a contraction of about 1.3% of current spending in that sector. So just think of it as $32 billion being vacuumed out of the system in a single year.
And it's vacuumed out simply because patients can no longer afford to use the services they need.
That's right.
So let's break that $32.1 billion loss down. Where is the financial pain most concentrated?
The losses are very heavily weighted toward facility-based care.
Meaning hospitals.
Meaning hospitals are the largest victims, yes. Hospital services are projected to see a $14.2 billion decrease.
$14.2 billion. That's 44% of the total revenue decline just hitting hospitals.
Correct.
To put that in real terms, what does a loss of that magnitude actually mean for, say, the average hospital administrator?
It means immediate forced triage. A $14.2 billion reduction nationally forces administrators to look at every single service line, especially the ones that are already losing money.
Like maternity wards.
Like maternity wards, trauma centers, specialized clinics. It means closing entire departments. It means implementing severe workforce reductions.
Layoffs.
Mass layoffs. And it also means cutting back on capital investments, deferring vital equipment upgrades, delaying necessary infrastructure repairs.
So this isn't just a number on a spreadsheet. This is the physical deterioration of the healthcare infrastructure.
It is. And it's a reduction in available services for everyone, even the people who manage to stay insured.
And the pain doesn't stop with hospitals.
No. Prescription drugs take a $5.8 billion hit. Office-based physician services drop by $5.1 billion. Other services lose another $6.9 billion.
And this spiral, it's driven by two things, right? It's the decreased payment from private insurers, and it's the fact that uninsured households just stop seeking non-emergency care. They stop going for preventative stuff, for elective care.
They only show up when they're critically, desperately ill.
Which leads us directly to the second blade of this financial assault, the inevitable spike in uncompensated care.
The other shoe drops. When uninsured rates go up, the demand for care that patients can't possibly pay for skyrockets.
Because people still break bones, they still need dialysis, they still end up in the ICU.
Exactly. The need doesn't go away, only the ability to pay for it does.
So what's the size of this projected uncompensated care spike?
Total uncompensated care demand is projected to increase by $7.7 billion nationally.
$7.7 billion.
Which is a sharp 12% jump from the current baseline of around $66 billion.
And again, I'm assuming the hospitals are the ones who bear the brunt of this.
They do. They'll be burdened by an additional $2.2 billion in uncompensated care demand. Physician offices will have to absorb an extra $1 billion, and prescription drugs will see about $1.5 billion in uncompensated demand.
So providers are facing this incredible double squeeze. They lose $32 billion in guaranteed revenue.
Right.
And at the exact same time, they're handed a $7.7 billion bill for services they are legally required to provide, but which they will never, ever be paid for.
That is the core unsustainable dilemma, and it forces us to look at the financing gap.
Because that $7.7 billion spike in uncompensated care, it doesn't just magically pay for itself.
Not at all. We estimate that providers themselves are projected to finance slightly more than half of this increased demand.
So they just absorb the cost and write it off.
They eat the cost. Then federal governments might cover about 30% of the increase through various programs, and state and local governments might pick up another 19%.
Wait, let me do the math. 50-something% from providers, 30 from federal, 19 from state and local. That's almost 100%.
Yes, the models try to account for all the likely funding streams. But here is the crucial takeaway. The largest single share of that new burden falls on providers as a massive, unpredictable liability.
And if that government funding, that other 49%, doesn't materialize or it's delayed?
Then providers have to absorb even more. Maybe more than half of that $7.7 billion spike. We're talking an additional liability of almost $4 billion.
And if they can't absorb it, that means they either have to shift those costs onto the insured population through higher prices, or they just have to make those service cuts we were just talking about.
Precisely. If that gap isn't filled, patients do one of two things. They either forego the care they need entirely, which leads to catastrophic health outcomes later on, or they wait until it's an emergency and they show up at the ER where the hospital is legally mandated to treat them and just eats the entire cost.
And that's why the financial decision at the macro level leads directly to community harm at the micro level.
Every single time.
As if the expiration of the PTCs wasn't enough instability for the system to handle, we have to look at the amplifying effect of another piece of legislation.
Right. The One Big Beautiful Bill Act, or OBBBA, which was passed in 2025.
And this just introduces a whole other layer of engineered fiscal damage.
The OBBBA is monumental. It's slated to cut over $1 trillion from health programs over 10 years.
$1 trillion.
A trillion with a T. And this isn't just targeting subsidies. This targets everything from Medicare payment updates to public health infrastructure and even eligibility criteria for programs. It's a comprehensive effort to significantly reduce the federal commitment to health programs across the board.
This feels like a political action that's been disguised as simple budgetary prudence.
One could certainly see it that way.
What are the specific mechanisms within OBBBA that really compound the damage that's already being done by the expiring tax credits?
Well, OBBBA has several provisions that just accelerate the loss of coverage.
Yeah.
For example, it includes new restrictions on premium tax credit eligibility for lawfully present immigrants.
So it tightens who can even access the marketplace subsidies to begin with.
Correct. And, maybe even more critically, it eliminates provisions for automatic enrollment and re-enrollment.
And that's a huge deal.
It's a huge deal. It means that millions of vulnerable people who rely on that passive enrollment assistance to maintain their coverage will suddenly just drop out. They'll lose coverage because of bureaucratic friction.
So the combined fiscal damage of OBBBA plus the PTC expiration, it results in a truly staggering reduction in the number of covered lives in the country.
It's projected to result in more than 10 million people losing coverage over the next decade.
10 million people.
And that includes the nearly 5 million losing coverage just from the subsidy expiration alone, plus millions more who lose it because of the new restrictions and the elimination of automatic enrollment under OBBBA.
And this leads to a projected increase in uncompensated care that's, it's almost impossible to comprehend.
The number is $278 billion over the 10-year period.
$278 billion in uncompensated care. A liability of that magnitude means that systemic instability isn't just a risk. It's the inevitable design feature of this policy combination.
It creates a death spiral for providers. There's no other way to describe it. We expect this to rapidly accelerate hospital closures, especially in areas that lack population density and strong underlying economies.
So rural facilities again?
The rural facilities that operate on razor-thin margins are the first to go. And to survive, the large health systems will be forced to make those service cuts and implement mass workforce reductions just to maintain solvency.
So the macroeconomic decision is essentially engineered to break the back of the American healthcare delivery system.
That's what the numbers suggest.
These national aggregates are shocking, but I think the story of this policy failure is really best told when you look at the geographic disparity.
Absolutely. This is where you can see how a state's policy choices, like whether or not to expand Medicaid, directly determine whether a community's healthcare system is going to sink or swim.
When we look at the data state by state, the impact is dramatically unequal, isn't it?
Oh, incredibly so. 14 states are projected to see their total healthcare spending decline by 1% or more, which indicates very concentrated economic pain.
So which states are feeling this impact the most acutely? What does that decline actually look like on the ground?
The hardest hit states are overwhelmingly concentrated in the South and the Southwest. Texas, for example.
I was going to guess Texas.
Texas is projected to see a massive $10.2 billion decline in healthcare spending.
$10 billion.
Florida is looking at a $6.7 billion decline, Georgia at $3.7 billion, and Mississippi at $1 billion. And these aren't just minor fluctuations. They represent several percentage points of their local healthcare economies just vanishing.
And the uncompensated care spikes, I imagine, are essentially a map of financial devastation in these same regions.
Exactly. The non-expansion states face the largest percentage increases in uncompensated care demand. We see Tennessee with a projected 29.2% increase.
Almost 30%.
Mississippi is right behind them at 29.1%, and South Carolina is at 26.9%.
And meanwhile, what about the states that did expand Medicaid and have tried to protect their populations?
They see a marginal impact. States like Connecticut, Hawaii, Minnesota, they see increases of less than 1% in uncompensated care demand. It's a completely different world.
So you have Texas seeing a $10 billion spending drop and a huge uncompensated care spike, while a state like Massachusetts is relatively insulated. What is the fundamental policy mechanism that's driving that divergence?
It boils down almost entirely to the state's decision on whether or not to expand Medicaid under the ACA.
Explain that connection for us.
Sure. In the non-expansion states, there's what's called a coverage gap. You have low-income individuals whose incomes fall between, say, 100% and 138% of the federal poverty level.
So they're too rich for traditional Medicaid in those states, but they're too poor to afford much else.
Exactly. And so they rely very heavily on the marketplace subsidies. They are the population that is most vulnerable to the expiration of the enhanced PTCs.
So when those enhanced credits expire, these millions of working poor are just immediately priced out of the market.
That's the cliff. Now, states that did expand Medicaid, they already cover that population.
Right.
So they have effectively shielded their provider systems from this specific shock. They have a more stable financing mechanism in place.
So the non-expansion states, by refusing the federal Medicaid funds, made their entire healthcare system critically dependent on these temporary enhanced ACA subsidies.
That's the political economy of the issue. When those subsidies vanish, the state is left with this massive liability that the providers, the hospitals, the clinics, they're the ones who have to absorb it.
It shows how the refusal of federal funds forces local providers to financially support the entire uninsured population in their community.
It's a direct cost shift from the state government to the private and nonprofit healthcare sector.
And this leads us right to the real-world consequences, the impossible choices that are being faced by people like David.
Yes.
He's a rural hospital administrator in Georgia, which is one of those high-impact states you just flagged.
David's story is the micro story of these macro numbers we've been talking about. He was operating an institution that was the anchor of its small rural community.
And as the Medicaid unwinding happened and the threat of the subsidy expiration loomed, what did he see?
He just watched his hospital's uncompensated care column skyrocket, as he put it.
So the local economy, the farmers, the mechanics, the teachers in his town, they were suddenly uninsured and relying on his hospital for life-saving care that they had no way to pay for.
Correct. Yeah. And his emergency board meetings, they stopped being about improving patient safety or adding new services. They started being purely about institutional solvency.
Just trying to keep the lights on.
He was facing a cash flow crisis where just a few more months of absorbing these massive unpaid bills meant outright bankruptcy for the entire facility.
Which would mean the entire community would lose its closest emergency room.
The ultimate disaster. And that desperation, it forced a terrible choice, didn't it?
It did. To prevent the complete closure of the hospital, David was forced to cut the most expensive and yet one of the most essential loss-leading services he provided.
And that was?
A maternity ward.
The maternity ward. This is where that abstract term fiscal responsibility becomes an act of community violence.
Absolutely. Because that financial decision, it immediately translated into immense human risk.
Now, expectant mothers in his community have to drive up to 90 minutes to get to the nearest city while they're in labor.
A 90-minute drive. A complication during that drive could mean the difference between life and death for a mother or her child.
Of course. And this decision, which was forced by billions of dollars being withdrawn from the system at a federal level, it just demonstrates that the high-level policy of cost-cutting is directly increasing safety risks and mortality at the local level.
And the pressure isn't just on the hospitals, it's on the workers inside them. It illustrates this deep precarity of the working middle class. Which brings us to the story of Elena, the ultrasound technician. She's a core healthcare worker, and yet the system is failing her financially.
Elena is exactly the person that the system needs to function. She provides essential diagnostic services every single day.
And yet, like millions of other people, she and her husband, who suffers from a chronic autoimmune condition that requires expensive ongoing treatment, they rely entirely on the stability provided by those marketplace subsidies.
They do.
And when that affordability cliff approached, she got that dreaded notice in the mail.
She did. She was notified that her monthly premium for her family plan was set to jump from $200 a month, which felt manageable for them, to over $1,200.
$1,000 increase.
$1,000 increase in mandatory monthly spending. For her family, that's the equivalent of a second mortgage or a huge car payment. It fundamentally changes their ability to stay afloat.
And the profound irony here is just inescapable. Elena is spending her days keeping other people healthy, but she can't afford to be a patient herself.
She and her husband faced the agonizing decision of whether they should just drop their coverage entirely.
And if they did that, they would risk total financial ruin if his autoimmune condition flared up.
A single hospitalization, a new specialty drug, it could bankrupt them. And this just underscores the total failure of the market-driven model.
If the people who actively work inside the healing infrastructure can't afford to use the very system they sustain,
then that system is fundamentally broken. Without these robust subsidies to make health insurance a stable utility, access just immediately reverts to being a fragile privilege.
And, this instability, it doesn't just hit insurance coverage, it hits the fundamental bedrock of future care, which is research.
That's a really important point.
We saw the immediate impact when the National Institutes of Health, the NIH, canceled over $2 billion in federal research grants as part of these government downsizing efforts. It created a really jarring and abrupt disruption.
It was catastrophic, and it really shows how far these policy cuts can reach. The NIH is the largest funder of biomedical research in the world.
So what did the sudden cancellation of $2 billion in grants actually do?
It affected approximately 3.5% of all ongoing clinical trials.
And what does that mean for the human beings who were in those trials?
That translates to over 74,000 participants who were mid-treatment.
74,000 people.
And for many of these patients, especially those with rare or aggressive cancers or complex autoimmune disorders, those trials are not supplemental. They're not just an extra.
They are the last resort, life-extending treatment path.
They're their only hope. So the discontinuation of a trial because of an abrupt funding cut means they no longer have a path to treat their illness. This causes immense mental instability, familial stress, and in some cases, it speeds up mortality because their disease gets worse.
So a policy decision in Washington to cut the fat translates directly to a patient on the oncology floor being told their last hope is gone.
And it's not just the discontinuation, it's the disruption to the continuity of care. The abruptness of these cuts meant that hospitals and research institutions had no time to plan.
So pharmacists and clinicians were suddenly burdened with this impossible task.
Exactly, finding alternative, safe, and effective therapies for thousands of patients who were relying on very specific cutting-edge trial protocols. It's an impossible situation.
And beyond the immediate harm to patients, we also lose crucial data for future generations of patients.
We do. Trials that were focused on infectious diseases and prevention were disproportionately affected. And, randomized control trials are the gold standard for establishing trustworthy causality in medicine.
Right.
When they're cut, the scientific community is forced to rely on less reliable observational studies. And that threatens the development of stable future therapies. The whole system is just too complex to absorb these abrupt financial shocks without patients falling through the cracks.
Which just confirms that policy is directly harming patients in real time and in the future.
It is. And the systemic pressure, the financial liability, the service cuts, the impossible choices, it all leads to a profound psychological crisis among the clinical workforce.
And this is where we have to get very precise with our language and distinguish this suffering from the generalized concept of burnout.
We must, because the solutions depend entirely on understanding the nature of the problem.
So let's clearly define these terms. Let's start with the standard definition of burnout.
Okay. Burnout is a chronic workplace phenomenon. It's defined by 3 dimensions: emotional exhaustion, depersonalization, which is a kind of cynical detachment from your job, and a reduced sense of personal accomplishment.
So it's a chronic mismatch between the demands of the job and the resources you have to meet them.
That's a perfect way to put it. And even before the pandemic, about 38 to 40% of physicians and nurses reported symptoms.
And by 2022,
that skyrocketed to over 60%. Burnout basically means you feel overworked and ineffective.
Okay, then there's the next level, which is moral distress.
Moral distress is more acute. It's the conflict you feel when you, as a clinician, know the ethically correct action to take for your patient, but you're prevented from doing it by some external constraint.
Like what?
It could be excessive paperwork, prior authorization delays from an insurance company, or an outright denial for a procedure you know is necessary. The harm is visible, and your hands are tied.
And finally, we get to the term that I think captures the deep, lasting institutional trauma we're seeing: moral injury.
Moral injury is far more corrosive than burnout or distress. It is a profound, lasting psychological and spiritual distress.
And it results from what?
It results from violating your own deeply held ethical code, or being unable to uphold it because of external factors. Or, and this is the most critical part, from feeling profoundly betrayed by a trusted authority or institution.
Your hospital, your leaders, maybe even the government that sets the rules.
Exactly. And it generates these lasting feelings of guilt, shame, anger. It's linked directly to PTSD, depression, and high rates of suicidality. It's a wound to the soul caused by a systemic failure.
And we have to include one more term in this mix because it's a daily demoralizing grind for so many: And that's administrative harm.
Yes. Administrative harm is the specific suffering caused by excessive and often pointless bureaucratic burdens.
Endless documentation, pointless performance reporting, prior authorizations that take hours of a nurse's or a doctor's day.
It's the feeling of being treated as a widget in a system that values metrics and billing codes over actual patient care. It just erodes your professional autonomy and your dignity.
And this moral injury we're talking about, it isn't rare. It's becoming widespread.
It is. A survey found that 39% of high-risk healthcare workers reported morally distressing experiences. But more disturbingly, 30% reported betrayal-based moral injury.
And that stems directly from decisions made by leaders or colleagues.
Yes. This is a crisis that is rooted in the systemic compromise of the mission of healthcare itself.
So what are the primary frontline causes of this powerful feeling of betrayal?
Well, the top drivers identified by workers trace directly back to the financial and operational shortfalls we've been discussing. The number one cause is the persistent inability to provide the standard of care due to chronic and prolonged short staffing or a lack of necessary supplies.
And the data connection here is just staggering.
It really is. Workers who reported being short-staffed for 3 months or longer were found to be 260% more likely to report moral injury.
260%.
This is the direct result of hospital administrators being forced to cut staff to meet these budget projections that are created by policy decisions like the OBBBA. When your hospital system demands that you work shorthanded for months on end, forcing you to compromise patient care, the system is betraying your fundamental ethics as a healer.
And the second major driver is feeling betrayed by leadership decisions during times of crisis.
Absolutely. Decisions like rationing vital personal protective equipment, PPE, or forcing the reuse of single-use equipment, or even just the perception that management was absent and disengaged during critical times.
And there's data on this too.
Yes. Workers who disagreed that their management prioritized health and safety were 5 times more likely to report moral injury.
5 times.
They feel that their leaders are prioritizing the balance sheet over their physical and psychological safety.
We also see this distress being caused by rigid policies that can strip away basic human dignity from the process.
Yes. For example, mandatory isolation rules that prevent a critically ill patient from saying goodbye to their loved ones, even when it might be medically unnecessary, that causes deep ethical distress.
And the feeling of being forced to provide what feels like futile care.
That's a huge one. Prolonging the suffering of a patient who has no chance of recovery purely to meet family demands or, frankly, billing codes, that violates the clinician's core commitment to compassionate treatment.
So we need to pull this financial policy discussion directly back to the bedside. Let's revisit Marcus, the diabetic patient who is in bed 4 in our opening narrative.
Marcus's story perfectly fuses macroeconomic policy with moral injury. He relied on the ACA subsidies to afford the high price of his insulin.
And when those subsidies were threatened, his calculus changed.
He saw the premium jump, he saw the overall cost of his drug rising, and he quietly started rationing his insulin doses to try to save money.
A decision that led him straight to the emergency department in diabetic ketoacidosis DKA.
And DKA is a predictable, preventable, and incredibly costly condition to treat. Marcus ended up in the ICU.
And his hospital stay cost the system how much?
It cost the hospital 50 times the price of the insulin he couldn't afford to buy in the first place. This is where the whole idea of saving money by cutting subsidies proves to be financially devastating in the long run for the system and nearly lethal for the patient.
And let's think about the nurse, Sarah, who cared for him. Her trauma wasn't just about physical exhaustion.
No. Sarah described the experience as a soul-crushing weight. She watched a patient suffer entirely preventable harm because of an economic ledger entry somewhere.
She provided excellent high-tech care to pull him back from the brink of death.
Only to be forced to send him home knowing that his survival was priced as a luxury he couldn't maintain. That experience violates the core oath of healing. It confirms that policy is actively placing financial barriers between the healer and the patient's well-being.
And that is the very definition of betrayal-based moral injury.
It is.
So we need to acknowledge who is most at risk here, and then we have to pivot to what possible solutions could mitigate this systemic trauma.
Okay. Well, nurses are consistently found to be at the highest risk.
Why nurses specifically?
Over 60% more likely than non-clinicians to experience moral injury. It's largely due to their constant, direct, prolonged exposure to patient suffering and death.
And ICU workers.
ICU workers who face frequent death and moral conflict, report a 70% higher risk. And critically, we see that workers with the least decision-making power are the most susceptible.
Which emphasizes that helplessness is a core driver of the injury.
It is. So if the problem is systemic betrayal, the solution must involve restoring agency and trust.
So how do we shift from just treating the individual's burnout to actually fixing the broken system that's causing it?
We have to focus on systemic interventions. We know that key protective factors that mitigate injury are things like strong community support among peers, dedicated time for processing and debriefing traumatic events,
And leadership.
visible and engaged leadership on the front line, and the ability for staff to propose and enact meaningful organizational changes based on their own experiences.
Okay, let's elaborate on those organizational changes. Because we can't just tell staff to talk about their feelings. We have to fix the system that's generating the feelings in the first place.
That's right. So what are some concrete systemic interventions?
Oh.
First, we need to implement what's called a just workplace culture, a place where reporting flaws, identifying hazards, and pointing out systemic compromises is safe, protected, and even encouraged rather than punished. Second, we have to treat understaffing as the systemic crisis it is. That means moving resources away from administrative layers and back to the bedside.
And what about that administrative harm we discussed? The pointless paperwork.
That's where initiatives like the dyad model and the getting rid of stupid stuff approach come in.
The dyad model, what is that?
The dyad model pairs a physician or another clinical leader directly with an administrator to share joint decision-making authority.
So it forces the administrator to understand the clinical reality before they impose some new policy.
And it gives the clinician a direct voice in resource allocation. It immediately counters that feeling of powerlessness.
And the getting rid of stupid stuff approach, I have to admit, that sounds a bit oversimplified, but also very necessary.
It's highly effective because it directly combats administrative harm. GRS, as it's called, involves formally soliciting feedback from frontline staff about the specific non-value-added administrative tasks, the stupid stuff that wastes their time.
Like excessive documentation for routine procedures or redundant performance metrics.
Exactly, or complex, unnecessary steps in ordering supplies. The hospital then commits to systematically eliminating a percentage of these tasks every single year.
So it restores professional autonomy, it shows respect for the clinician's time and intelligence.
And it fundamentally counters that feeling of being treated as a widget. By tackling administrative harm head-on, you directly reduce a major driver of moral distress. You're fixing the system instead of pathologizing the individual.
Okay, now let's pull back to the highest possible level and compare the U.S. system against 9 other high-income nations.
Australia, Canada, France, Germany, the Netherlands, New Zealand, Sweden, Switzerland, and the UK.
When you zoom out to that level, the U.S. picture goes from being distressing to, frankly, absurd.
The comparison is definitive, and it's very sobering. The U.S. ranks dead last overall in health system performance among these peer nations. We are the severe outlier. And this ranking persists despite one monumental fact. The U.S. spends far more of its gross domestic product, its GDP, on healthcare than any other country.
How much more?
Over 16% of GDP in 2022, and is projected to exceed 20% by 2035.
And our peer nations, the ones that get better results.
They typically cluster between 8 and 12% of GDP.
So we are paying twice as much as our peers to get the worst overall results.
We are, by definition, running a low-value system.
Where is that failure concentrated?
It's rooted in the foundational policy choice. The U.S. is the only country in this entire comparison that lacks universal coverage.
Leaving 26 million Americans completely uninsured.
And that structural defect creates immediate, profound access problems that no amount of specialized high-tech care can fix.
And even for those of us who are insured, affordability remains a barrier that our peers have largely eliminated.
That's the tragedy of fragmentation. Because the U.S. system is this patchwork of thousands of different plans, nearly a quarter of insured Americans are still considered underinsured.
Because of cripplingly high deductibles and co-payments?
Right. Our peer nations simply do not tolerate that level of financial jeopardy for their citizens.
We need an analogy to make that financial barrier really clear. Let's compare the U.S. out-of-pocket cap to, say, Germany's.
Okay. Let's consider a middle-class family earning, say, $80,000 a year. In a high-performing system like Germany, their patient out-of-pocket spending for the entire year is capped at 2% of their income.
$1,600 maximum.
$1,600. Once they hit that cap, their medical costs are covered for the rest of the year.
And in the U.S. marketplace, the out-of-pocket cap for a family can be
Nearly $19,000.
$1,600 versus $19,000. That difference is the line between a manageable expense and instant financial ruin.
It is, and it shows the radical divergence in philosophy. Germany views healthcare as a right, and they ensure financial security. The U.S. treats it as a consumer commodity, where even with insurance, financial catastrophe is always just one major illness away.
And that's why the U.S. ranks last on equity. We demonstrate the largest income-related differences in cost-related access problems and experiences of unfair treatment.
Our policy ensures that your ability to pay remains the primary determinant of your health.
And this fragmentation also contributes to massive administrative inefficiency, which ties right back to the moral injury we were discussing earlier.
The enormous complexity of dealing with thousands of different insurance plans, prior authorization rules, billing codes, it forces both patients and providers to spend huge amounts of time and energy on bureaucracy instead of care.
So the U.S. essentially employs an army of administrative staff just to track and negotiate payments.
A cost that high-performing countries largely eliminate through streamlined single-payer or highly regulated multi-payer systems.
But here's the most counterintuitive finding in this whole comparison. The U.S. does have one area of strength, and that's the care process itself.
That's right.
The U.S. ranks second globally in this domain, things like prevention, safety, coordination for specific services. This suggests that American doctors and our technology are excellent.
They are. This ranking reflects the success of high-quality specialized medicine and vigorous value-based care efforts. It shows we excel at delivering specific preventative services like mammograms and flu vaccinations when people can access them.
So the quality of the hands doing the work is often superb. But the fatal flaw, the paradox, is that this excellent care process does not translate into excellent health outcomes.
This is the crux of the American failure. Despite ranking second in delivering high-quality medical interventions, the U.S. ranks dead last in actual health outcomes.
Our life expectancy is 4 years below the average of the 10 nations studied.
And the U.S. has the highest rates of preventable and treatable deaths.
What does this policy disconnect fundamentally prove? Why do we have some of the world's best doctors, but one of the least healthy populations among our peers?
It proves that high-quality, high-tech medical intervention cannot overcome fundamental systemic failures in access, in equity, and in public health.
The problem isn't the skill of the surgeon.
It's the design of the system that keeps the patient out of the clinic until they require emergency surgery.
Let's break down that system design failure a little bit further. Why does the market model inherently undermine good outcomes?
Well, there are two main reasons. First, the U.S. fundamentally underinvests in primary care. Our system is specialty-driven, which is expensive and fragmented.
And high-performing systems do the opposite.
They use robust primary care, the general practitioner, the family doctor, as a mandatory low-cost gatekeeper. This ensures continuity of care, it manages chronic conditions effectively, and it prevents expensive acute episodes down the road.
Because U.S. primary care is often so difficult to access or inconvenient even for the well-insured, patients just skip routine maintenance.
And they end up in the ER, which is the most expensive and least effective way to receive care.
And the second reason?
The second reason is the failure to integrate social health. The market-driven system focuses narrowly on treating disease, not on addressing the social determinants of health.
Things like poverty, housing instability, food insecurity.
Right, which account for the vast majority of poor outcomes. Countries with universal systems recognize that spending money on housing assistance or public health campaigns saves massive amounts of money down the line in reduced hospitalizations.
But the U.S. system, driven by these short-term insurance cycles, lacks the coordination and the political will to make those crucial long-term public health investments.
So the system is designed to reward profitable specialty procedures while ignoring the low-cost foundational elements, primary care and social health, that actually create a healthy population.
The global comparison just confirms that equitable access is the prerequisite for a healthy nation.
And the U.S. chooses to pay exponentially more for fragmented, highly complex, and ultimately substandard results compared to nations that simply guarantee that access.
This entire deep dive has synthesized the data from the highest political decisions all the way down to the lowest point of patient care. The expiration of subsidies and the massive spending cuts like the OBBBA are cascading into a financial and operational crisis for providers.
The $32 billion in lost revenue, the nearly $8 billion in new uncompensated care burden. It's an impossible situation.
And that instability is accelerating hospital closures, it's destabilizing crucial services like maternity wards in non-expansion states, and it's forcing dedicated healers to absorb the psychological trauma of moral injury.
They're being forced to choose between institutional solvency and their ethical commitment to the patient, a choice that confirms the system is actively betraying them.
The knowledge gained from comparing the U.S. to its global peers is just so stark. The U.S. commitment to a market-driven, fragmented system results in spending far more for the worst outcomes, perpetually eroding access and equity.
And the current policy direction, marked by this rising uncompensated care and catastrophic workforce trauma, is actively eroding the ethical and financial foundations of American healthcare. The global evidence is clear. The only path to a sustainable, healthy system is one that secures equitable access for all, because without that foundation, even the best medical technology in the world is rendered useless.